MD for Wound Care People, and this today is a virtual lunch meeting. We're bringing you this virtual lunch meeting in place of our regular, industry representative visits. And today's session is in partnership with L&R. So I'd like to thank those for supporting this event. And today we're going to be talking about Suprasorb P Sensitive, and why that is the foam for your patients. Our speakers today are Simon Barrett, he's the lead Tissue Viability Nurse Specialist, and Adam Occleshaw, who's one of the brand managers over at L&R. So I'm joined by you, gents. Simon, can you hear me still? Are you okay?
I am. Thank you very much, Alex.
Good. And yourself, Adam, how are you?
Yeah, good, Alec. Yeah, thank you very much, Alex.
Brilliant. So just going to crack on. The same as our other live events, you can see that we're presenting these from our homes or offices. So if there's any technical issues, please do bear with us. You will actually get a certificate of attendance for your CPD folders for viewing this event today. The link will be available at the end, along with copies of any slides. The same with our Facebook Live events. If you've got any questions, this event is all about this wonderful new product, and it's fairly exciting because launching a new product, whatever it is, in the middle of a pandemic is always difficult. So I'm sure that, Adam, you've had your challenges in being able to get this information out. So I'm certainly very much looking forward to hearing all about it. And for you watching at home, ask as many questions as you possibly can, and we'll put up some links and things like that for you to be able to pick up some resources at the end of the event. Without further ado, I'm going to hand over to Simon and Adam, and I'll join you back after the chat for the live Q&A. Over to you.
Great. Thanks, Alec, for the introduction, and thank you for everyone for joining us on this virtual lunch meeting this afternoon. What I wanted to do first was just to kind of set the scene with wound care at the moment, and these are all stats which I'm sure we're all really familiar with from the guest data. So we know that wound prevalence is increasing, and there's about 7% of the UK with an active wound that needs intervention at the moment. If the prevalence of wounds are going up, then unfortunately the costs attached to treating these and the resource that the NHS must place into treating these wounds is going to increase too. The paper obviously goes into the challenges of wound care in terms of the type, but I think crucially for this presentation today, the exudate that comes out of these different wounds varies too. So you've got increasing prevalence, a range of different wound types, and then what dressings should you use on these wounds as well. It's a hugely complicated picture at the moment. We know that silicone-based foams are incredibly popular, and we know that because they're just so versatile. So here's some stats just to give you the role in which silicone-based foams play in the NHS today. Just to give you a flavour, it's about 11.8 million silicone-based foams were used in 2020. And to give you a bit of a baseline about how large that is, in the same year we used 7 million SuperAbsorbers. And if you try and put a cost attached to that, it's about £30 million spent on silicone-based foams in that year alone. So a huge area of focus for the NHS. So what's the problem with that? We've got increased prevalence, increased types of wounds, exudate challenges. The NHS is under the biggest pressure it's ever been to address these patient outcomes. But we've still got this class of products in silicone-based foams that are hugely popular, and they're really good at what they do. But because they're so widely used and so prevalent, are they misused sometimes? Are they used on wounds where they shouldn't be? And is that contributing to the cost attached to them? We did a virtual lunch meeting before on Suprasorb P Sensitive, and thank you for your participation in that, because we asked you some really key questions about silicone-based foams. Here are some results from that previous lunch meeting, and what we asked you was, what kind of exudate level do you use on silicone-based foams? And the answer was ranged. So silicone-based foams in that low to moderate area, but there were some of you who were using them in the highly exuding stage as well. And then we also asked, what must a silicone foam do? What must it be good at? And the answers were varied too. So it must be atraumatic, it must be conformable, it must have good absorbency, and the list goes on. So you start to paint this picture of a silicone-based foam as a really high bar to meet in order to meet your clinical outcomes for patients. And at that point, it'd be really easy for me to go into Suprasorb P Sensitive, but that's not what I'm going to do today. I think that the evidence of this product should speak for itself, and I think I'm really glad that Simon can join me on this call and present the great work that he's doing with his team, because the study that we have for Suprasorb P Sensitive in the real world is really powerful. But before I do that, it's increasing pressure on the NHS at the moment to look at new products. And as Alex said himself, launching a new product in a pandemic is difficult, but I think launching products generally in the NHS, we need to partner with the NHS more. And I personally think industry should do more to support clinicians to make evidence-based decisions. So that's why we commissioned this study, and really grateful for the help of Simon and his team here, because with increasing time pressures that clinicians have, you're constantly looking for the best product clinically. You're constantly looking for the most cost-effective product for your formularies and to make sure that you have the best product available for your patients. But how can you do that with the time pressures that you have these days? And if you are going to look at an evaluation, maybe that you'd only choose small cohorts of patients. You may only be able to try it on 2 or 3 patients. This is where I think industry should really support more and provide studies like this on 50 patients to give you that confidence in this product to move to it on its clinical robustness. So without further ado, I really want to give Simon the time to showcase his great work. And I'd like to pass it over to Simon Barrett now to run through the study. Thank you.
Thank you very much, Adam. So first of all, I'd just like to say a big thank you to the team that I work with at Humber Teaching NHS Foundation Trust, because the team consisted of a number of staff. I'm just going to say the names very quickly: Adele, Amanda, Sophie and Donna, and then we had outside help and support as well from Brenda. So we had a really good team, and when I say the team, they're a team of TVNs, healthcare assistants and podiatrists, and I think that's really interesting to consider as well, because we've got a good range of people that are taking part in this study. On top of that, as Adam's already said, we've got 50 people or 51 wounds that were recruited onto this evaluation. We wanted to look at the different types of wounds that we were taking on. We wanted to look at the levels of exudate. We wanted to look at the initial results when we put the dressing on and how it compared to previous dressings that we'd used. And we also then wanted to compare it again to the end results, or how it performed, from its start point to its end point over a 2-week period. We also wanted some clinician feedback, so that all the people that contribute to the study gave us their feedback on the product as well. And ultimately, we wanted the patient feedback, because if it wasn't right for the patient, it's never going to be right for the organisation, and certainly not, right for everybody nationally. So it was really important that we had everybody's feedback. We had good quality evidence to prove that this product was as good as, if not better than, existing products that we were currently using or are available within the NHS. So we looked, as I said, at 50 patients, and the average age was 71, with an age range from 42 to 99 years of age. There was 20 males and 30 females, so a good spread. And what we also looked at was a wide range in type of wound as well. So we had leg ulcers, pressure ulcers, diabetic foot ulcers, surgical wounds, skin tears and traumatic wounds. That was making up the 51. So we looked at these wounds, each one for 2 weeks. So the end point wasn't healing ultimately, but it was to look at some various markers to see how it performed. So we looked at exudate level. As Adam's already said, one of the things that you wanted to see was how it managed with exudate. And when I say it, I mean a foam. So we looked at, most foams are designed to absorb low to moderate levels of exudate. And what we did, we recruited on with that low to moderate guideline, if you like, but we also went with a couple that were high levels of exudate with a thick viscosity as well, so that thick custody type exudate that's coming out, and gave it that big test, if you like. We also looked at the pain, and we scored from 0 to 10, 10 being the worst or the most severe pain that the patient was suffering. Mostly, thankfully, the patients were suffering at the 0 to 5, with a few that was creeping over from 5 to 10. And again, it was really important that we assessed how their pain reduced or stayed the same or deteriorated, unfortunately, if that was the case with this product. We also thought it was really important to look at the peri-wound skin, because obviously, I always say this, and I use the analogy of a springboard. When you're a swimmer, you're diving in, always make sure your feet are secure as you're about to spring off, because if you don't, you're going to belly flop down. And it's the same with these wounds. If you've got a poor peri-wound area, you're not going to get epithelial contraction, because it's not going to be able to jump, springboard off and start swimming across the wound. So when you looked at these wounds, almost half of them were healthy, peri-wound skin, but there was also quite a large number that were macerated and a few that had erythema and a bit of excoriation there as well. So we had to take that into account when we was putting the dressing on and to see how it performed throughout the evaluation. So the next one was we looked at the length of time that the wounds had been in existence, and you all know that obviously the longer the wound's been in existence, the longer it's going to take potentially to heal. And it does make me wonder, do we need to go back sometimes and take the wound back to the acute phase and we reevaluate with a full holistic plan? So in this particular case, the greatest range, if you like, was between 8 days to 6 months, but there was a few that fell into that acute wound stage and there was a few that fell into the very chronic wound stage. On the body maps that you can see that we looked at a very wide ranging of anatomical positions as well. So we looked at feet, we looked at lower legs, we looked at hips, we looked at elbows, buttocks. So there was movable joints, there was surface areas that are not always the easiest to keep a dressing on. And obviously when you've got your diabetic feet, that's another issue in itself. We then went on to look at, as I've said, the number of patients we recruited in total was 50. We looked at the age and we considered all of these things, but the big question is, can Suprasorb P Sensitive deliver? And could it deliver on the things that you were asking us, me, you as clinicians? Exudate control. Was it atraumatic at removal? Was the peri-wound skin protected by the dressing? And what was the clinician's preference, or what was their experience, and what was the patient's preference and or experience? And again, if we don't get all of these bits right, when I say we as clinicians, we're going to have a non-concordant patient, and it's going to make it very difficult to get that wound to progress if the patient doesn't actually want to enter into that agreement, that relationship with us. So it's vitally important that we're confident with the product and we're confident that it can do these things. So the first application on the results, we've got ease of application. It came out as being 38% better than existing foam products that were being used. 62% said it was the same. Nobody said it was worse. Conformability was 40% better. 60% said it was the same. 0% saying it was worse. And then we went on to patient comfort. So the patients had said that 36% said it was better, 64% said it was the same, and 0% said it was worse. Now, when you say worse than what or better than what, it was the existing foams that we currently have on formulary, and there's a range of foams on our formulary at this present moment that we were comparing against. And then post-evaluation, obviously we wanted to see if it still continued to perform well throughout that 2-week period. And again, ease of application was scored at 30%, 33% was excellent, 32% was very good, 33% was good, and only 1% said it was poor. And it's really important that we stress that, you know, there's never going to be any one single product that's going to be right for everybody, which is why we need that variation of products for patients. And then we went on to conformability, and at the end of the study, it said 37.5% said it was excellent, 27% very good, and 35% said it was good. 0% again saying it was poor. And the patient comfort, 88% said it was comfortable. Exudate control, 12% said it was excellent, 37% very good, and 43% good, 8% poor. Now, you've got to consider we tried this product on very highly exuding, thick viscosity custard-like, so it may have struggled a little bit at that, but generally speaking, good, very good, and excellent was 92%. And then we looked at the atraumatic removal. 39% said excellent, 27% very good, 32% good, and only 2% poor. Certainly in all the cases that I looked at and my colleagues, it was easy to apply, it was easy to remove, and it was very atraumatic for the patient. And the clinician score, 80% of the clinicians said it was a very good product and they'd consider using it again in the future. And there's a couple of case studies that we'll have a look a little bit deeper with that as well. So it did score very, very high. So if you look at it just briefly, this way of looking at it in summary, if you like. So the first application, 100% said it was good or above. So good to excellent for ease of application. 100% said it was good to excellent on conformability. 100% said it was good to excellent on patient comfort. And again, at post-evaluation, 99% said it was good or excellent at ease of application. 100% said it was conformable to a good or excellent standard, and patient comfort was recorded as 88% satisfactory or better. Exudate control, 92% said good to excellent. Atraumatic removal was 98% good to excellent. And the clinician scores, we've already said, was 80% found it satisfactory or better. Also, what we've got is a little graph to the right-hand side as you look at it. The grey, the darker grey side, if you like, is pre-evaluation. And what it's actually indicating is that you had high levels of erythema maceration in that category in the pre-evaluation state. And then post-evaluation, you had a much higher healthy column of skin. So what it's actually saying is that this product, not only did it lock the fluid in, it protected the surrounding skin, it prevented maceration, it prevented erythema. One thing it slightly struggled with was that there was a little bit more excoriation, but overall it performed really, really well with much higher scores in the healthy skin. So excellent outcome for the product there. The first case study then is a 79-year-old gentleman. And this gentleman, when we look at case studies, I think often we pick the more difficult ones or the most gruesome or the most gory. Well, I haven't actually done that in this particular case. I'm just going to tell you a little bit about him. But he's a gent presented with a skin tear on his right elbow. He's had it for 3 days. Treatment to this point had included an alternative silicone foam dressing. Initial wound measurements 3 centimeters by 2.5, and you're thinking, well, that's not much of a wound. And the initial assessment, there was 50% granulation, there was 50% devitalized tissue, which had already removed with a blade at this particular point. Healthy peri-wound skin, score was 1 out of 10 for exudate, so the volume was low and it was low viscosity. 1 out of 10 for pain, so it was low levels of pain, even though it was a superficial wound and you would expect it to be higher. And Suprasorb P Sensitive was planned for twice-a-week applications. And the thing with this gentleman, which we've not highlighted at this point, the trust that I work for is a combined general and mental health trust. And this gent had significant mental health issues, and he was very untrusting of the nurses, very untrusting of the dressings, and he would only have what he would have on. And to get him to actually agree to use this product and evaluate it for us was quite a thing for him, and he absolutely loved it. He absolutely loved it, and he loved it because at 11 days it was improving wound status, the peri-wound skin remained very healthy, the exudate volume remained low, and the wound reduced in size, as you can see from the 2 images. And it was rated excellent for ease of application, absorption, patient comfort, ease of removal, and conformability. So this, as I say, after only 10-11 days, it went on to a very reduced wound size. There was good epithelial contraction. The granulation tissue was good, and it only took another 8 days and it was completely healed. He was very happy with that. His wife was very happy with that because obviously his anxiety levels went down, and he was a much improved gentleman because of that. So although we're looking at wounds, it's sometimes that bigger holistic picture that we've got to look at. What was the root cause? So was it his mental health? Was he having an acute episode at the time? Did he trip, slip, fall? Is there anything else that we need to do to put in place to reduce any further risk? But the acute problem or the wound was dealt with using the Suprasorb P Sensitive, and the overall clinician score for this gent was 9 out of 10, and the patient score was 10 out of 10. It was on a very difficult position on his elbow, so a very movable joint. It stayed in place well. It did everything that he wanted it to do, and it was comfortable, and he was very confident in that product and the way it worked for him and his wound. So the second case study is an 83-year-old lady presented with a surgical wound on her right hip. It'd been in existence for 2 months, and as you can see by the image, it had closed by primary intention, but there was a little area that had dehisced with a sinus, and unfortunately this wound became very infected, and she was having antibiotics intravenously and then orally. So wound position along the suture line, it only had a 1 centimetre depth. And again, you're probably thinking, oh heck, well, there's nothing too difficult about that. It all looks good. The tissue's healing well. The surrounding skin's good. I will say this, it was 100% granulation on initial assessment. It was a very healthy peri-wound skin. It was 3 out of 10 for volume of exudate coming out with a moderate viscosity, and it was 2 out of 10 for pain. What she did say though, that all the other products that she'd been on, and certainly within the acute trust, had caused her to itch, and she'd had a sensitivity rash to it. So she struggled from a compliance concordance point of view to wear a foam dressing, and often she'd take them off, and that created a bigger risk then to infection getting into the little open area, and the risk of infection back into that bone, and the risk to sepsis was a major problem. So although we're looking at this and saying, well, it's not much of a wound to look at, what went on before we got to this point was a major issue, and what could happen again if we didn't reduce that risk could be a major point. So 14 days later, you might think to yourself, well, not an awful lot's changed there. The wound status was static, but the peri-wound skin was very healthy, and there was no further itching. It reduced the exudate volume, and when I say it, the exudate volume reduced, and it was well managed within the foam dressing. And it was rated excellent for patient comfort, excellent for ease of removal, excellent for conformability, and very good for ease of application and absorption. The reason when I say it was very good, we had a little bit of an issue, if you like, because of the location, and a hip shape had changed completely. But we did find that, after we adapted, it was absolutely fantastic for it. So overall clinician score was 9 out of 10. Overall patient score was 10 out of 10. Patient wouldn't go back to using her previous foam dressings that the acute trust had supplied her with. And so we supplied her with a continuation of dressings after the evaluation of the 14 days. And she went on to complete healing with no further issues with regards to infection, no irritation, no excoriation. So for her, she absolutely loved the product, which is really good to hear, because obviously we get a concordant patient, we get a healed wound, a healed patient, and it's a massive cost saving to the organisation and to the NHS. So I will just hand you back to Adam now for the final few slides, but thank you very much for that so far.
Great, thank you, Simon, and thank you again for all the hard work that you and your team did with this study. It was great hearing about all the patient case studies that you had. I know we struggled to pick just 2 out of them, but I think that we made the right choice with these 2 because they were very emotive for you and your team. For everyone who's not had an opportunity to see Suprasorb P Sensitive, I just wanted to share kind of some of the technology that's in the dressing as a brief overview, and then up to allow time for some questions for Simon and his team, if you have any on more work on the study. So here are some layers of Suprasorb P Sensitive, and we know before that a silicone-based foam must do lots of things. So we've classified them as 4 categories here, as the 4 basic things it must do. It first of all must absorb the exudate. It's got to distribute it across the dressing, lock it away, and then let it release out the top as well. So the layers have lots of different functions that allow it to achieve that. So first of all, starting at the bottom, you'll see that we have an OptiSil wound contact layer. So there's no requirement to have a contact layer in addition to Suprasorb P Sensitive. It has one built in, and it has a very unique perforation pattern that allows it to be very atraumatic. Next, after that, you have a first layer of PU foam, which starts that absorption process, and then it's immediately met with a distribution layer. And this is really important because if you've got a 10 by 10 dressing and the wound is very small, you want the whole 10 by 10 to be used to maximize the efficiency of the dressing, the wear time of the dressing, but the cost of the dressing as well. So the distribution layer ensures that the whole 10 by 10 or whatever size that you're using is used to its maximum effect. After that comes the lock stage. After all this hard work, it'd be a real shame if that exudate regressed back into the wound and led to maceration. So it's really important that we lock it away at a distance away from the wound bed. And then lastly, that release stage, it allows vapor to leave the wound bed for patient comfort and extra absorption, but it doesn't allow any fluid or bacteria into the wound still. And it's clear by design to allow you to have an indicator when that dressing is ready to be changed. In terms of all the technology that Suprasorb P comes with, it doesn't need to be expensive for your budgets. Here are some indicative costs from the drug tariff. These are all market-leading brands, and you'd be familiar with all of them. But Suprasorb P Sensitive comes in at a significant price differential to allow you to realise some real cost savings whilst not compromising on quality of your silicone-based foam. If you're on NHS supply chain, there is still a price differential there as well. I would be happy to talk to you about that in your account. So as I say, I don't want to take time up away from questions for Simon, because his team have done some great work in terms of showcasing the real world data of Suprasorb P Sensitive, and hopefully you'll agree that that study that we did for Suprasorb P Sensitive is robust. A range of patient types, a range of wound types, a range of exudate types, and it was with lots of good results there. So to close, and before I hand back to Alec, some of the things that you can do after this lunch meeting is, if you want some more information on that paper, there's a link with this session to download your own copy of it, and I really encourage you to do it. There's lots of information that we weren't able to cover today on some extra patient outcomes that would benefit you and your patients. If you want to request a pack too, that's something that you can do in the link below, and get your hands on Suprasorb P Sensitive to experience it yourself. Just for your awareness as well, it's completely available through prescription, shared business services, and NHS supply chain as of now in November. And we're at hand. So as I said before, if you want some more information, or if you want to go through the details specific to your account, or some really specific questions about some patients under your practice, by all means, please get in touch and we'll be happy to help. So other than that, I'd like to hand back to Alec, and hopefully we can go through some questions.
Brilliant. Thank you, Adam. Thank you, Simon. Really interesting. One of the questions that has come through already just is, can people access the content of the study that you were referencing, Simon? Is that something that we can get a link out to?
Yeah, I believe you can. Obviously, there is a link to it, as Adam's already said. And obviously, if anybody ever wants to contact me personally, they can contact me through Humber Teaching NHS Foundation Trust, and I'm always willing to share any information on a one-to-one basis as well. Because sometimes I think when documents are written, it all looks very good and it all looks very presentable. But if you ever want to speak to me or one of my colleagues who undertook the evaluation, more than happy to share the information that we found with the product.
Okay, brilliant. So there should be some links actually on the screen for anything that anything that either of you have mentioned today. And what we'll do is the copy of this presentation will be on our website as always, with any slides and any links to anything that has been mentioned as well. So that should be available from tomorrow. A couple of questions coming in. The first one is for you, Simon. This is would you debride the wounds before applying Suprasorb P Sensitive?
It's an interesting one, this, because we were talking about this at the JCN yesterday, and I think it's vitally important that we prepare the wound to heal, whether that involves debridement, cleansing, or whatever form we take or use. One thing I would say, though, as a caveat to that, is only do that if it's safe and appropriate to do so. So I wouldn't recommend debriding if I've got a compromised limb or a diabetic foot without specialist advice. So take that advice first before undertaking any form of debridement. I think that it's a question in itself almost, because what we understand of debridement or cleaning, are they one and the same thing, or is it something a specialist should do? And I think we often get confused that we use the word debridement and it automatically pings up getting a blade out and sharp debriding it. We've got to think that there's autolysis, which is you're creating a warm, moist environment to help the body to debride. And there's the cleaning products that we've now got available to help with mechanical debridement, whether that's DebraSoft or All Prep or whatever. They are available, and there will be good products for preparing that wound. I think it's vitally important as well that we disrupt those biofilms that are present in the chronic wounds, and that could be anything from 70 to 100%. So again, vitally important that we do prepare the wound before we start putting the foam dressings on, or the secondary dressings.
So we've done quite a few sessions over the last couple of years on sort of wound assessment and that sort of initial assessment as to whether debridement is required. So you can find all of those things on our website as well. Simon, another question for you. This is quite a specific one. So are the are the dressings okay to use on patients with frail skin without causing trauma on removal? That's probably actually one for the two of you, I'd say. Simon, your experience of it?
Yeah, my experience, definitely. Obviously, you've got the silicone contact layer, so it makes it very traumatic. And of the 51 cases or wounds that we used and the 50 patients that we used it on, generally speaking, as high as 90+% were saying it was very comfortable, it was very easy to apply, and it was certainly very easy to take off. We didn't get any complaints with that at all. And I think that's, again, vitally important for the relationship that we're building with our patients. So yeah, I would certainly recommend it for atraumatic removal and atraumatic use.
Brilliant, thank you. Anything you want to add to that, Adam?
No, couldn't have said it better myself. No, leave it as what Simon said. He's a clinician.
Okay, well, so product-based question for you then, Adam. What sizes are available? And do you have additional shapes such as heel, sacrum, etc.?
Yep, so I guess the easiest way to say it would be there's no issue with sizes or shapes. So all silicone-based foams have the border, non-border, border light variants, so do we. And also the main sizes that you're going to be using are the 7.5, kind of 10 by 10, 12.5. And then we have some larger sizes going up to about 20 centimeters. We also have some anatomical shapes too, like the sacrum and the heel. We also have a multi-site, which may be appropriate for maybe some more movable joints, or maybe somewhere where you don't want a square shape visible. So a huge range of sizes and variants available to you. And
I'm assuming all of that information is available either by contacting you, and we'll put some links up on there as to how people do that, or available available on your website as well. Okay, so that sort of answers two questions in one, because the next one was specifically about sizes. The next question is, when would you use a foam as opposed to SuperAbsorb, as opposed to a SAP, S-A-P? I'm
Superabsorbent product.
Oh, right. Okay. Yeah. Well, I've never heard of that before.
I'm guessing.
Yeah, possibly. Well, that would make sense, but I've never heard it called a SAP before. This is.
No, I don't think I have.
So when would you use a foam as opposed to a super absorbent product?
I think from my point of view, obviously, if I'm using a super absorbent, I would like to think it's because I've got a wound that's leaking or exuding high volumes of exudate with probably that thick viscosity. And I would tend to use a foam where there's a lower level of exudate and possibly a lower level of viscosity. But the one thing I would say about a foam is, and certainly with this particular foam, it is very conformable. And you don't tend to always get that with the super absorbent. So if you've got, like we've mentioned with that gent in the case study, he had a very movable joint in his elbow, it'd be very difficult to apply super absorbent on there. Plus it wouldn't be required because his level of exudate was low to moderate. He had a superficial wound, and the Suprasorb P Sensitive was, perfectly suited to that type of wound. So I think it's clearly, for me, based on the level of exudate and the type of exudate that's coming from there.
Yeah, and Adam, do you have resources available then that show clinicians from your product range? Because obviously you've got your FleaVisorb product. Do you have resources which would show people when to use one over the other?
Yeah, so we have some resources to really help there. So we can support clinicians and patients all the way through from debridement to wound contact layer with Low Pro to Suprasorb P, and then to FleaVisorb Pro as well. The main thing is just use the right product that needs for the patient and their exudate challenges. So we have a nice little visual and a guide that we can share with clinicians to make sure that you can step up or step down as appropriate.
Okay, brilliant. And I understand that you're making samples available for anybody that wants to receive a sample. So there should be a link in order for you to be able to fill in your details available on the screen at some point. So if you are interested in receiving a sample, then you can either send us a direct message via the chat function, or you can copy the link that comes up on the on one of the slides and fill in your contact information. And Eleanor will very kindly send you out some samples for you to try. The next question is from Jackie, and this is again, it's a specific wound-related question. Simon, have you used this foam with patients who have fungating wounds?
In this evaluation, no. I'm just trying to think. So I'm just buying myself some time, Jackie. I don't think we did use it on any fungating wounds at that particular time. No. I can be honest there. Say I haven't. All I would say to you is that it would perform in the same way, if not similar way, to any foam with a silicone-based contact layer. So, you know, if you was thinking of using any other foam, then this will perform just as well. And I think the one thing that stood out for me with the 50 patients and the 51 wounds was the fact of there was no irritation at any point caused by the adhesive layer. So I think that's really important, and I think it's vitally important for somebody who has got a fungating lesion as well. But again, you've got to consider what are your other outcomes for this wound. You know, what else do I need to do as well? I'm certainly not a big believer in the use of sandwich dressings, and if you can get away with using one product for one wound, that would be ideal.
Okay.
Alec, I'm just going to add to that if I can. I'm aware of a clinician who's actively using Suprasorb P for fungating wounds at the moment. So if that person could make themselves known to us, we can hopefully link those two together, and these two clinicians can talk about their experiences together. So I'm aware it's being used in one particular case study elsewhere in the UK at the moment. So I can hopefully share that information with this person.
Okay, brilliant. There you go. That's a good answer there for you, Jackie. So if you want to share your information with us, then we'll put you directly in touch with a clinician who's actively using it on fungating wounds at the moment. Big question.
Can I ask you? Sorry, can I ask a question, Alex, as well? Then sorry, while we're doing it, could I also have the contact details for that patient, that person as well, Adam? Just so you know, I'd be interested to know what they found as well. Thank you.
I think that's fair. I'm sure we can arrange that. That's fine.
Good.
Thank you.
Massive question here, Adam. This is like one of the most important questions, I'm sure, and I'm surprised it's taken us until 8 questions in for somebody to ask it, and that is it expensive?
So it's very cost competitive. As I've shared on one of the slides before, there's significant cost savings on drug tariff, and there's also cost differentials available on NHS supply chain as well. But it's still a really effective dressing, as we've seen, and we've got some other data as well to pit it head to head against other dressings, which we can share with you. So you've got a highly effective dressing is the main thing I want you to take away. But by the way, it's also offering significant cost savings too. So you don't have to compromise and pick one or the other. You can have both.
Okay, well, and another question: can the product be used under compression? Simon, did you use it under compression?
Yeah, yes, we did. We used it under compression hosiery, and it worked perfectly well. Again, you know, I'm not going to say that anything works better than anything else, but I will say it works as well as our existing products. So yes, under 20 millimeters of reduced compression, it worked well of hosiery. And when we put a leg ulcer kit of 40 millimeters of mercury compression on, it also worked really well as well and locked it in and stopped that lateral wicking and excoriation that could develop. So yeah, it works very well. Thank you.
Brilliant. I think that probably concludes the Q&A for now. If we haven't managed to get through to any of your questions, any questions that you've asked, we'll put those to Adam and Simon, and then we'll put a document with the answers to those online on our website, along with a copy of this presentation. As I said at the start, launching a new product, typically, you know, reps would come out and visit you and show you the product. You can have a look and a feel. And for obvious reasons, we've not been able to do that. So this is a great way for you to understand what is new and innovative in the marketplace. And Eleanor, as I said earlier, very kindly offered to send out samples to anybody. So please do either send us your information or take a note of the link that should be on your screen now, which will show people, which will direct you to a place where you can fill in your contact information, and we'll get some samples sent out to you. Thank you very much for giving up your lunchtime with us. I hope that you've all had a sandwich and a drink while you've been watching. And Simon, it's great to see you as always. Thank you very much for your presentation today. And Adam, again, likewise with you. Thank you very much. It's been very interesting. I'd like to thank my team and everyone at Mole. We're back next week. So please do come and join us then. Keep an eye out on our Facebook page, like and follow us for more information on that. Certificate links should be available now. We look forward to seeing you at some point next week, and I'd just like to wish you a good day. Thank you very much.
Thank you very much, Alex.
Yep.